right, cool. All right, so thank you so much for coping with the technical difficulty earlier. Apologize for that. Um, and thank you for allowing me to present today, June. So for this meeting, I'd like to present a paper by I don't know how to spell it, Rajaraman et al.
Adityan, yes.
Is that how you pronounce it?
Yeah,
Rajaraman?
Adityan. That's the A is Adityan.
Mm,
Actually met the guy. So excited.
amazing. And it's a paper that he had written with Hanley and Donnelly and all his other colleagues. So it's in the volume 55 of the Journal of Applied Behavior Analysis. And this paper focuses on trauma-informed applications in behavior analysis. Next slide. So first, I'd like to share a bit about why I chose this paper. The reason why is that I felt that it's right up my alley in my line of work here, but it's also when I read the paper, I thought it was a very good one to increase our awareness and self-evaluation when we deliver services to our clients. It's good practice as behavior analyst, and it's like when I read this article, it's just made me more conscious to adhere and always go back to the ethic code of behavior analyst. And it's a step in the door to follow up with further research related to trauma-informed care. And there are other couple of studies mentioned in the paper that I thought was quite interesting to follow up on. So that's why I chose this paper. Okay, so has anyone ever come across trauma-informed care in their practice? Hold on.
Yes,
Yeah.
I did. Just through CEUs. I've done a couple on trauma-informed care, but I think in recent years it's getting more and more popular, and I've been hearing the term being used more. But I would still like to learn more about it.
Yeah, it's I'm learning too, so I'm about this, and it's I guess because of the population that I work with, it's sort of shaped me to do this. Actually, Cindy, Felicia, and you know Cindy, right?
Yeah.
Yeah. So she actually recommended me to present on this paper. So yeah, so I thought it was kind of cool. But anyway, so I'll move ahead with this. Okay, so I'll start by going over some background information provided in this paper, but I'd like to talk about the trauma first. So in the paper, there's this quote regarding trauma. It states that individual trauma results from an event, series of events, or sets of circumstances that is experienced by an individual as physically or emotionally harmful or life-threatening, and that has lasting adverse effect on the individual's functioning and mental and physical, social, emotional, and spiritual well-being. Trauma can occur in any point of a person's life. Adverse childhood experiences have featured prominently in understanding short-term and long-term difficulties associated with trauma. These are reported frequently by individuals receiving behavioral health services, in which 61% of adults experience at least one adverse childhood experience, and 16% have experienced four or more of these experiences. And this is information provided by the Center for Disease Control in 2019. So individuals respond differently to trauma. So it varies from person to person, varying from no response to severe behaviors or health consequences such as PTSDs. High-risk group includes children and adolescents in foster or residential care. and individuals with developmental disabilities are more likely to experience potential traumatic events. So what does trauma-informed mean? Harris and Falla defined being trauma-informed as to know the history of past and current abuse in life of the consumer with whom one is working, and to use that understanding to design service systems and accommodate the vulnerabilities of trauma survivors and allow services to be delivered in a way that will facilitate consumer participation. So this implies that behavior analysts taking this into consideration should acknowledge these trauma experiences. We need to develop assessment and treatment approaches that are sensitive to these traumas of the individuals. Okay. So although publication provide emerging evidence of the applicability of behavior analytic approaches to supporting those who have trauma, the field, behavior analysis, has not yet defined what being trauma-informed is within a behavior analytic context. So the aim of the paper is to address barriers to discussing trauma in behavior analysis. It aims to outline a framework for a trauma-informed approach to ABA and explore strategies that might fit well with this approach. The discussion of trauma can be difficult in behavior analysis for a couple of reasons. So in the paper, the authors stated three. One is the conceptual confusion and interpretation difficulty regarding the phenomenon itself. Second is the conceptualization of the causes, and the third is evidence. So the first barrier, conceptual confusion and interpretive difficulty. It's difficult in a sense that we looked at overt and covert behavior, right? There's physical trauma and there's mental, emotional trauma. So physical trauma, we know that we can observe. So it's extrinsic, whereas emotional trauma can be intrinsic. The causes of the trauma. I'm sorry, I got this typo. It should say the causes of trauma are extrinsic. So the causes, the environmental variable, are extrinsic, but the experience of trauma is intrinsic, which is an internal process. Experienced trauma has long-lasting effect and focuses on how a person feels, being fearful, helpless, angry, and the concept of trauma is associated with perceptions of experiences such as loss of control, betrayal, broken trust, and so forth. So looking at that, we as behavior analysts, or in the field of behavior analysis, we run into the difficulty of how the experiences of trauma can be observed without the individual being able to communicate these experiences. We won't know what the person is going through. So it gives us, it puts us in a very uncomfortable territory, I think, in an uncomfortable place, as our line of work relies mainly on observable behaviors, right? Which can be specifically identified, defined, measured. We can, immediate actions to provide consequences and modify variables immediately. So it's a hard concept to grasp or work around, this whole trauma thing. The author argues that the presence of trauma should be defined by a person's behavior, is defined by a person's behavior, whether it's verbal or otherwise. And they argue for a functional definition of trauma that focuses on the behavior rather than the psychological state. The second barrier is the conceptualization of causes. So processes such as stimulus equivalence, derived relational responding, and stimulus generalization can be useful in explaining these traumas after they have occurred. So months or years after the traumatic events have occurred. Our practice in behavior analysis is focused on current contingencies that is within reach of direct observation and manipulations. So it's very hard, you know, it's different when we work on behavior that's maintained by access. You know, there's things that we can immediately do in that environment. But when it comes to trauma, because of the long-lasting effect, it's something that we don't have immediate control over. And we don't have also, it's not something like, you know, like when we work with behaviors, we can manipulate the antecedent or the stimulus. We can remove it, we can present it, right? But when it comes to trauma, we can't do that. We can't, it's hard to do antecedent approaches, you know, to the behavior, to decreasing the behavior or what have you, because it's too remote, far in the past. So again, like, it's also unclear, like, how impactful our, yeah, when we deal with trauma. It is also unclear the degree to which information regarding a person's history, which is the remote contingencies, affect the conclusions drawn from an FA results that we do now. Okay, the last barrier is the evidence. So there's growing acknowledgement in trauma prevalence, and it resulted in, like, you know, a commitment, a general commitment, and a framework for including or providing trauma-informed care. However, there's lack of widely accepted data-informed practices demonstrating the outcomes, the improvement in client outcomes. The evidence of effectiveness of trauma-informed care approaches tend to focus more on the staff knowledge and the perceived efficacy rather than the client outcomes. So there's this issue of evidence. Okay. Do you have any questions, or can I move on?
Can we go back to the there's just a previous slide? I think I missed the last point.
Yeah, that's correct. Let me know when I can continue.
Do you want to read more?
Oh,
Or
no,
are
no, I'm
you-
good. Oh,
You're good?
All good?
yep.
Okay, cool. All right, so next slide. The next slide, hold on a second. Okay, so in this section, the author of the paper proposed a framework within behavior analysis that incorporates the, I'll just abbreviate it, TIC, into practice. These 4 commitments, so there's 4 commitments to the practice, and these are: 1, to acknowledge trauma and its potential impact; 2, to ensure safety and trust; 3, promote choice and shared governance; and 4 is the emphasis on skill building. So these are the 4 commitments to the practice of trauma-informed care in behavior analysis. To acknowledge trauma and potential impact, here are some things that the paper suggested. To understand, one of them is to understand the current behaviors. Current behaviors may be ways of the individuals to adapt or cope to past traumatic events. So it's like, I don't know, like say, for example, a certain behavior, a repetitive behavior, or a self-injurious behaviors, or other forms of behaviors that can be harmful or non-harmful. It's their way of coping with these events. Individuals with, sorry?
I thought, sorry.
Okay. Individuals with physical abuse may respond to severe SIB, to mild forms of physical prompts. So it's important that, you know, when we implement our strategies, approaches in teaching or in behavior reduction, that we observe, we continuously be aware and observe for avoidance behaviors, and whether there's negative emotional behaviors as well. So being cautious and tentative will allow us as behavior analysts to avoid re-traumatization. So being more aware and self-conscious about, you know, or being trauma informed, it makes us more cautious on what we implement. So sometimes we think that, you know, physical prompts, even partial physical prompts, is harmless, you know, but for a person that has gone through some physical abuse or even sexual abuse, those can be very traumatizing for them, or you get a negative reaction. They make, so our our intervention or the approaches that we deliver can actually trigger that trauma again. So it's important to exercise caution to developing treatments. Okay. So we also have to pay attention to not use restrictive practices. I know that sometimes it's needed and it's justified, but you know, we always try to before we even go to restrictive practice, we always have to try to do the least intrusive approach and strategies, focusing more on positive reinforcement. And when these least intrusive don't work, then we have to go through the proper channel of restrictive practice. So it's also important to note here that when we work with our clients, there can be documented and undocumented histories of trauma. Some barriers could be cultural. Some cultures are not, how do you say it? They're not comfortable talking about this or providing information about this. But also, like, when our clients are nonverbal or have limited language, they can't tell people what they're going through or what has happened to them. So sometimes like these information histories can go undocumented. That's why we have to, as behavior analysts, have to rely on our observation skills to evaluate what the responses look like, and in what stimuli does this behavior occur in. So again, like, the risk of trauma is more prevalent with intellectual and people with intellectual and developmental disabilities, because they have that communication deficit. And again, because how do we know? It really depends on verbal reports. So the second commitment to TIC focuses on safety and trust. It recommends that we as practitioners establish a safe physical, emotional, and respectful environment where our clients' needs are met. And clients have safe therapeutic practices throughout their intervention. When we attempt to establish the safety and trust in our practice with our clients, it's also important to keep in mind the definition of both concepts. So safety is defined as free of impending harm while behaving in a context with minimal aversive stimulation, as indicated by no or minimal engagement in avoidance or escape of that context. Dinsmore in 2006 noted that the features of the environment that signal predictable periods devoid of aversive stimulation can be operantly conditioned as safety signals. So safety signals is, it just informs the individual that the environment is safe. There's no aversive stimuli there. So examples can be like a quiet environment, or the presence of preferred activities, or availability of the reinforcers. Another example could be parents included in sessions because, like children have a strong, in most cases, children has strong bonds with their parents. Its parents are their safety net. So when parents are in the room, they're more cooperative. They feel more safe. When a client doesn't feel safe or comfortable, discomfort, it's hard to engage in learning opportunities. But when some parents come and join, you have that opportunity to teach more easily. So the definition of trust also is the reliable interaction in which a client independently approaches the practitioner and readily communicates for reinforcers across contexts due to reinforcement history with the practitioner. So developing trust can give the client a feeling of being safe, and that forms into emotional safety as well. The ethics code for behavior analysts is aligned with the trauma-informed care. It compels practitioners to not only describe the objective of the behavior change program, but it also it also encourages, pushes or emphasizes to minimize potential risk in ABA practice and research as well. And they ensure the selection of the least restrictive procedures necessary for effective treatment. So when it comes to trauma-informed care, we have some resources available, like on the internet or literatures, research and stuff like that. But however, the authors argued that we in the field of behavior analysis need a handbook on ensuring emotional safety. So it's like a one book that you can go to. The emotional safety and trust should be prioritized to the same degree as physical safety. So how do we create the safety and trust? And it's not an easy thing to develop. However, we already are doing that. We are already implementing procedures or skills, teaching skills that promote that. When we first start a session, meet the child, we pair and build rapport, but we don't do that just like in the beginning, but it's a continuous process throughout the relationship with the client. In the intervention, we pair and build rapport with them. It's a continuous process. We continuously establish reinforcement history. We be a giver, not a taker. In the process, when we deliver treatment, we also can utilize joint attention to build that trust and providing a safe space for the child. And also, when we have procedures that signal warning signals, we terminate that procedure. So like switching off the behavior to prevent the escalation. And to switch off the behavior, now we have to reinforce the behavior, right, from occurring. Like if if it's escape maintained, then we have to remove the stimuli that triggered the escape behavior. But it is better that way rather than going through a whole extinction burst, especially when it's dangerous behaviors. In the paper, it's mentioned that staff that do restrictive practice or restraint practices may become reflexive condition motivating operations. So reflexive condition motivating operation is a type of condition motivating operation that is established when a stimulus comes before and signals the onset of pain or something aversive, making it so that the removal of this warning stimulus is just as negatively reinforcing as the removal of the pain that it signals. But staff that are correlated with the removal of the aversive stimuli have a reinforcing value to the individual, to the client. So they're more reinforcing because the removal of the aversive stimuli gives the individual a sense of safety. So in behavior analysis, it can seem contradicting to reinforce behaviors or dangerous behaviors. However, this is to switch off that behavior to prevent that escalation, because that behavior can be risky and be unsafe for the client or others. And switching off the behavior is actually can prevent the use of restraints. When the behavior can be switched off, the therapist can have the opportunity to build trust and then continue teaching. So what they're saying is that it's better to, even though we are reinforcing the behavior, it's better to switch off. But when it's switched off, it provides that opportunity for us to regain rapport, build rapport, continue teaching, or even do like manding or something more productive, more positive, that focuses on skill building. Because when we go through that extinction burst, it's time consuming and very effortful, and in the end, it's very exhausting for both the client and the therapist. So you lose that opportunity. So it's better to switch off. Okay. Future research should examine immediate and long-term effects of reinforcing rather than restraining during episodes of dangerous behaviors by evaluating the problem behavior, the cooperation with adult instruction, the frequency of the experienced restraint, and the social validity of the procedures and outcomes. Do you have any question before I move on? All good. So we're on slide 20, right, June?
Yep.
Yep. Okay.
Can you see? Yep.
Okay. So the third commitment to TIC is to integrate practices that support client control, promote choice and independence of the individual. It minimizes the risk of re-traumatization, minimize the risk of replicating prior trauma dynamics in which the individual feels powerless, and it gives a sense of control and autonomy over the individual's daily life and decision-making. So the definition of choice, in which Catania 2007 has defined choice as the omission of one among two or more alternatives, and usually incompatible responses and preferences, the selection of one alternative more frequently than another. The definition of shared governance is a situation which all participants in the therapeutic process have a voice and operates in collaboration with one another. And code 209 of the Ethic Code for Behavior Analysts takes these into consideration. All right, so next we'll just quickly mention 3 studies that was mentioned briefly in the paper. The study promotes choice and governance, and 2 of these studies are from Hanley, and it's on slide 21, and then Ferguson on slide 22. So Hanley in 2010 summarized the body of research with concurrent chain procedures. In the study, it enabled recipients of ABA service delivery to choose the behavior intervention that they preferred. So the recipients expressed preference for a certain type of service. They were repeatedly asked by the researchers to pick and experience one among multiple alternative options of the service delivery. So Hanley argument is that all participants of the ABA services should be able to participate in shared governance in treatment selection and development of the treatments, regardless of their capacity to communicate or language capacity. In 2005, Hanley did a similar concurrent chain procedure. The preference for, so it evaluates the preference for intervention for dangerous problem behavior. So both participating children in the study chose an intervention package, surprisingly, that included punishment procedure rather than one that relied only on differential reinforcement. But this produces client-based and database values to guide the selection of treatments based on the client's choice. So I think there's more, like there's more buy-in into the treatment, and therefore, when there's buy-in, the treatment can become more effective because there's that commitment to participate in it. In 2019, Ferguson did Ferguson did evaluate 142 studies that reported measures of social validity in Java. Only 6% incorporated intervention choice in their study procedure. So this suggests that in behavior analytic research, choice is rarely incorporated, and even less clear, like how much is choice being incorporated into practice. Okay, so in practice, therefore, it is important to investigate choices further in terms of its risk and benefits. With the choices incorporated, it should also include choices not to participate in treatments. So among the types of treatments that are offered to clients for them to make a choice, there has to be also a choice for them to not participate in the treatment. Okay, and the 4th commitment to TIC is to empower the client by acquiring adaptive behavior. So acquiring adaptive behavior is a form of empowerment. Recovering from trauma occurs in relationship that supports learning and skill development. That's a good point that the author has made in the paper. And skill building is not something that is new to us. It's always been on our plate. It's something that we can contribute to the field, to the approach or the movement of trauma-informed care. We as behavior analysts see problem behavior as a skill deficit or excess, which can be taught by learning to engage in functionally equivalent alternative behaviors that are more appropriate and safe, such as functional communication. So instead of engaging in dangerous behaviors or challenging behaviors, the client can use functional communication, can say, I want to break, I don't want to do this. That can be more effective and more and safer. And it also it can immediately meet their needs. Okay, so in this section, we'll explore what a trauma-informed care framework will look like in application. So in this framework, it suggested that that behavior analysts prioritize client assent, opting in or out of treatment, independent of language ability. And for behavior analysts to actively avoid programs and procedures that can potentially cause or occasion trauma responses. Things such as extinction, physical prompts, timeout. Sometimes our tone of voice and body language can also occasion trauma responses. So we have to be very conscious of that. And there are, like, with different behaviors and condition where the clients is in, let's say, for example, if they're in a state of fear or state of frustration, or a state of, like, if they're manipulative, there's different tone of voice and body language to match that. So again, like when it comes to trauma, if the person's experiencing fear, when we communicate with them, we shouldn't use like a heart overexcited tone of voice, but more of a calmer voice. We tell client what we're going to do first before we do it. So those things, and body language, open body language is promoted, where our hands are visible. We shouldn't be putting our hands in our pocket or in the back of our head, in the back of our back, in the back of our body, or have it crossed in front of us. So those are body language that can actually help out when we deal with individuals or clients that have traumatic experience. It's important to closely monitor any negative emotional responses to features of the therapeutic setting, behavior expectation, or strategies, and to adjust treatment to target more immediate skills, such as transitioning to work areas, relinquishing preferred items, skill readiness to learn, and also utilizing differential reinforcement. Okay. So the next slide talks about the enhanced choice model, again by Rajaram et al. In 2021. So they evaluated 5 clients who engage in problem behaviors that are escape maintained. These clients displayed extreme discomfort when they were physically managed by others. And they did a modified version of the skill-based treatments from what was introduced by Hanley in 2014. They use prompting and differential reinforcement to develop communication, toleration, cooperation skills in the presence of the conditions that were shown to evoke the problem behaviors in baseline. The modification in this study provided ongoing options for participant to participate in the skill-based treatment with an alternative to hang out instead with in another space with non-contingent access to the reinforcers that is responsible for the behavior, or they have the other option of opting out, the not participating at all in the therapeutic context. the clients were given details to what to expect in the treatment space, including challenging situations that they may encounter. They also arrange opportunities for the clients to choose what challenging experience they want to experience and what skill to practice during the adult-led periods. And the study also committed to a hands-off model, so physical management was not allowed in the enhanced choice model. Although the children were routinely exposed to and taught skills under these evocative conditions correlated with the problem behavior, they were always safe from physical management. They had the autonomy to participate in their own treatment throughout the process. They had shared governance with the planning of treatment goals, and they were taught important social skills to help them navigate evocative situations. The outcome of the study was that all the children completed the study and acquired complex repertoire of adaptive skills. None of them displayed any dangerous problem behavior throughout the treatment process. And all the participants chose the skill-based treatment context during 90% of the opportunities, despite having the option to just hang out or to not participate at all. So this suggests that the children in the study viewed the therapeutic context as reinforcing and safe. So in conclusion of the paper, it encourages behavior analysts to take on more a proactive approach to trauma-informed care. And it is possible to incorporate trauma-informed care into ABA, especially within reach in most settings where the services are delivered to individuals that are at risk. The trauma-informed care approach in ABA can increase dignity and humanity in which we treat our clients by potentially avoiding traumatization or re-traumatization, increase the social acceptability of our ABA services, and expand the scope of service deliveries to areas where there may be a mismatch between the nature of ABA procedures and the unique problems experienced by individuals that have trauma. Lastly, there's just a few guidelines consistent with the trauma-informed care. So the Ethics Code of Behavior Analysts provides some code for this. These codes are 209, 2.14, 2.13, but in a nutshell, it pushes to promote clients' involvement, choice, and self-determination, and prioritizing reinforcement-based procedures, meeting the diverse needs of the client, including those with trauma, and respecting clients' preferences and choice, obtaining consent and assent, and maximizing benefits and reducing harm, including re-traumatization. So these are the ethics code of conduct that is in line with this model. So to close up the presentation, like knowing all that we know about trauma-informed care, there are some things that can be discussed. These are just a few things. We don't have to discuss this, but it's basically more on like what is applicable in your population. But a few is like ABA has been knownly criticized for its practice, that it can be traumatic because of the extinction. But ABA has much evolved since, and our techniques and practices have evolved to include a lot more things and to heavily focus on positive reinforcement. One of the discussion can be, what about the least to most prompt versus most to least prompt. We know that most to least prompts are effective in learning new skills, but how does that go with a person who's sensitive to touch? What about if the parents or caregivers are the ones that's experiencing traumatic events? Because the skills that we teach are generalized at home by parents, but if parents don't have the capacity and continues to have traumatic events, how does that go? But just a few things. Okay, so that's the end of my presentation.
Thank you so much, Tanti. That was a really good topic. And like I said, I found it quite interesting. Oh, sorry, 1 second. Unfortunately, I have to leave in a few minutes. So I just wanted to join the discussion before leaving to say a few things. Whenever I listen to any conversation about this topic, trauma-informed care, I feel two ways. The first way is we kind of already do a lot of these practices, right? A lot of them are, like you said, within the code of ethics. So a lot of them, like pairing and giving choice to some extent to the client, treating them with dignity and creating a safe environment. But at the same time, there are other areas which seem to me like they're very difficult to apply. For example, giving the client a choice in treatment. I feel that you need to be a really, really, really good practitioner to be able to do that, because sometimes we struggle to come up with even one treatment plan or one type of treatment for some clients. So to come up with different choices and to allow the client to choose which one they like. So I feel like this is not very applicable because we struggle sometimes to train our BTs to apply basic teaching strategies, error correction, prompting correctly, let alone doing something as complex as allowing the client choice. And then my final point is with the last study you talked about, where the children chose what treatment they wanted. That requires the client to be able to have a certain level of skills, right? To be verbal, to communicate. So I feel like, how is that fair? What about the lower functioning children or clients? How will they participate in making that kind of choice? And another thing that I will mention, for maybe Stella can say more about, Think, the center I used to work at, started to apply teaching children ascent and descent. But I wasn't working there at the time, so I didn't get to practice that in person. Maybe Stella was there when they started doing that, and I wonder how that was going.
Sorry, I wasn't there then.
So I think I think everybody's thinking the same thing, right? I mean, how are we doing that if we've never seen it happen? How do we do that if we are never trained, right? And this is where we kind of have to sort of reinvent the wheel ourselves, since for better for worse, ABA is evolving and becoming more trauma informed and more respectful of people with disabilities. And I think this is why we have this discussion groups like this to talk about it. So if I'm not mistaken, the 2005 study where the participant choose which intervention they wanted to do, I don't believe they were verbal. So I think I've read it, but I read it like 4 years ago.
I know I've seen one of Hanley's studies that was like that. But if you can, Jan, if you can go up a few slides, I don't know what gave me the impression that they were higher functioning.
Yeah, the paper doesn't only briefly talks about that, but doesn't go into detail. So that's why I think, like in the beginning, I think these are studies that can spark curiosity and maybe worth, looking into.
Towards the end,
I
it was
think-
one of the last.
Sorry, I think one of your slide mentions currently trauma reports has been, requires verbal abilities or something.
Yes. Yeah.
That might be it. Amna. I don't know.
Yeah, it's hard. I think the paper also the paper mentioned that with individuals that don't have that capacity to communicate, it's hard to see whether they have gone through any trauma. So what the I believe, like I read in the paper, that it's better for us to just like not assume. I don't know how to explain it, but sort of like it's better to do. It won't hurt, even though they haven't gone through trauma, because we're just putting ourselves in a conscious state of what we're doing and making sure that what we're doing is safe for the client, but also we are engaging in conscious observation of any negative responses. So I think that's like the paper argued, like even though we don't know, it's better. It doesn't hurt to take this approach.